Good day, and thank you for standing by. Welcome to the All Tribes Call, seeking input on proposed distribution of additional graduate medical education residency positions for IHS and tribal hospitals. At this time, all participants are in a listen-only mode. After the speaker presentation, there will be a question and answer session. To ask a question during the session, you will need to press star 1 on your telephone. If you require any further assistance, please press star 0. Thank you. I would now like to hand the conference over to Susan Carroll. Please go ahead.
Thank you, Ashley. Good afternoon, everyone. This is Dr. Susan Carroll, the CMO for the CMS Division of Tribal Affairs. This afternoon, the Division of Tribal Affairs, in collaboration with the CMS Division of Acute Care with the Hospitals and Ambulatory Policy Group, are glad that you joined us. The call today is an all-tribes call seeking input on the proposed distribution of additional graduate medical education, or GME, residency positions for IHS and tribal hospitals. The call is an overview of the fiscal year 2022 hospital inpatient prospective payment systems for acute care hospitals and the long-term care hospital prospective payment system and proposed policy changes in fiscal year 2022. This is related to the distribution of additional GME residency positions under Provision 126 of the 2021 Consolidated Appropriations Act. I'll now turn it over to Joe Brooks to further discuss Section 126 and explain further also the Balanced Budget Act of 1997 on the limit or cap for the number of residents as part of a hospital GME program. Over to you, Mr. Brooks.
Thank you very much. This is Joe from CMS. I think it's probably best to start with a quick summary of the Balanced Budget Act of 1997 regarding the cap. So the calculation of both direct GME payments and the IME payment adjustment is affected by the number of FTE residents that a hospital is allowed to count. Generally, the greater the number of FTE residents a hospital counts, the greater the amount of Medicare direct GME and IME payments the hospital will receive. Congress, through the Balanced Budget Act of 1997, established a limit on the number of allopathic and osteopathic residents that a hospital may include in its FTE resident count for direct GME and IME payment purposes. Under Section 1886H4F of the Act, for cost reporting periods beginning on or after October 1st, 1997, a hospital's unweighted FTE count of residents for purposes of direct GME may not exceed the hospital's unweighted FTE count for direct GME in its most recent cost reporting period ending on or before December 31st, 1996. So following that, under Section 1886 D5BV of the Act, a similar limit based on the FTE count for IME during the cost reporting period is applied, and that's effective for discharges occurring on or after October 1st, 1997. Dental and podiatry residents are not included in the statutorily mandated cap. So on to Section 126 of the Consolidated Appropriations Act, this also known as the CAA. So the CAA of 2021 included a key provision affecting Medicare payments for graduate medical education. And this key provision in Section 126 of the CAA makes available 1,000 additional full-time equivalent residency slots at a rate of no more than 200 slots per year beginning in FY 2023. The law requires that in order to receive additional slots, a hospital must qualify in at least one of the following 4 categories: hospitals in rural areas or treated as being located in a rural area under the law, hospitals training a number of residents in excess of their GME cap, hospitals in states with new medical schools or branch campuses, and hospitals that serve areas designated as health professional shortage areas, also known as Hipsas. Additionally, the law requires that at least 10% of the slots go to hospitals in each of the 4 categories, and that no single hospital can receive more than 25 slots. CMS is required to notify hospitals of Section 126 slot distributions by January 31st of each year of implementation. The first such notification occurring by January 31st, 2023. The cap slots will be effective on July 1st each year of implementation, with July 1st, 2023 being the effective date for the initial implementation of Section 126. CMS proposed implementation of Section 126 of the CAA in the May 10th publication of the FY 2022 IPPS LTEC PPS proposed rule. We proposed that the application deadline for the initial implementation of Section 126 is January 31st, 2022. We also propose that hospitals will apply to CMS to receive additional residency slots under 126 using an online application system. A link to this online application system, as well as instructions for accessing the system and completing the online application process, will be made available on the CMS DGME website. In the proposed rule, CMS indicated that the additional Section 126 residency slots should be focused on the populations in areas with the most need, and that utilizing Hipsas could accomplish this goal. We proposed that a hospital would apply for an additional residency position to be used at least 50% of the time in the Hipsa at locations that were part of the hospital and serving that Hipsa's associated population. In the case of a mental health only Hipsa, the position would have to be used to provide mental health services. CMS proposed to prioritize applications from hospitals according to the degree of the health professional shortage in the Hipsa as measured by that area's Hipsa score. The Health Resources and Services Administration, HRSA, assigns a numerical score from 1 to 25 to each Hipsa that reflects the severity of the provider shortage and the proportion of the population at or below the federal poverty level in that area. CMS proposed conditions that needed to be met to determine if a hospital serves a Hipsa for purposes of Section 126. First, the hospital needs to attest that the residency program for which it is applying treats the underserved population of the Hipsa. Second, the program needs to have one or more training sites that are physically located in the Hipsa. Third, the qualifying sites, these one or more training sites physically located in the Hipsa, need to be provider-based to the hospital, for example, on the main campus, or if not on the main campus, considered an outpatient part of the hospital. And then fourth, at least 50% of the training time for the program needs to occur at the qualifying training sites. The law specifies that no hospital may receive more than 25 additional residency slots of the total 1,000 available, and no more than 200 slots per year can be awarded, as mentioned earlier. We stated in the proposed rule that we believe that the number of hospitals submitting applications would far exceed the maximum 200 slots available for distribution each fiscal year. Therefore, we proposed to limit the size of the award to 1 FTE per hospital per year. CMS also sought comment on an alternative distribution method for the first round of applications, where hospitals would receive prioritization for these residency slots based on the number of statutory categories under which they qualify. Hospitals that qualify under all 4 categories would receive the highest priority. Finally, in order to ensure that the residents are educated and trained in culturally and linguistically appropriate policies and practices, CMS also proposed to require that all applicant hospitals attest that they meet the national standards for culturally, linguistically appropriate services in health and healthcare, also known as the National Class Standards. Now I'll turn it over to Adam.
Thanks, Joe. So we received 2 comments on IHS tribal or urban Indian organization facilities and their participation in the Section 126 additional residency positions. One is from the Tribal Technical Advisory Group, and the other is from the Alaska Native Tribal Health Consortium. Both letters noted that many Indian health providers would be eligible under the statutory criteria for 126, but expressed concern that there was no assurance they'd receive awards. Both letters requested that CMS set aside a portion of the 1,000 Section 126 positions for Indian healthcare providers and for some awards to be tied to service requirements in tribal communities. The Tribal Technical Advisory Group also requested that CMS remove administrative impediments to GME participation by Indian-operated hospitals, probably referring specifically to Section 126 FTEs, given the context, but it wasn't explicit. The Alaska Native Tribal Health Consortium expressed concern with the 1.0 FTE limitation on GME awards that was part of the methodology in the proposed rule, and recommended larger award sizes to limit the awardee cost share. The consortium also expressed support of the proposed distribution method that would prioritize slot distribution by Hipsa scores. These 2 comments raised a few questions for us. First, given the statutory requirements for eligibility and minimum distributions for certain hospital types, how might the program be designed to best facilitate service and ITU facilities by these additional residents, either as applicants or as training program affiliates of applicants? Second, in the context of Section 126, what strategies for developing partnerships for resident training programs would ITU facilities like to pursue? And who are your prospective partners, IHS tribal hospitals or non-IHS tribal hospitals for training? And how would you characterize your relationships to them? And I'll note that training programs often rotate residents through multiple locations, and while some may meet eligibility criteria in the statute or feature elements prioritized in the proposed rule methodologies, the proposed rule also provided examples in which rotating sites of eligible applicants might also benefit from the awards. And the last thing I'll note, something of a footnote, is that we did an analysis using Hipsa data that found that 91.6 of 850 ITU facilities are either in a mental health or primary care Hipsa. And that's all for a summary of our initial thoughts in these comment letters. So, operator, we're ready to now take some questions.
Thank you. As a reminder, if you would like to ask a question, please press star, then the number 1 on your telephone. Again, that is star 1 on your telephone. To withdraw your question, press the pound key. We'll pause for just a moment to compile the Q&A roster. Once again, in order to ask a question, please press star 1 on your telephone. There are no questions at this time. I will now turn it over to Donald Thompson for closing remarks.
Thanks. Can everybody hear me okay?
Yes.
All right. Yeah, so, I mean, if folks think about questions or have inquiries after the call, I don't know, Dr. Carroll, what's the best way for those to get transmitted to us if folks have anything after the call's over?
Sure. We do have a tribal affairs at cms.hhs.gov that people could write their questions and comments to. I don't know if if your division has a mailbox that might also be useful, but we're happy to take those questions and relay them over to you. That's at tribalaffairs@cms.gov. www.hhs.gov.
Yeah, we don't have a specific one for Section 126, and that, I understand if folks don't necessarily have questions right now. As was sort of mentioned earlier in the call, there currently tribal and IHS hospitals don't have caps on their number of residents because for the most part, IHS and tribal hospitals are not currently operating residency programs themselves. They may be taking rotations from other hospitals, but they're not operating residency programs with caps themselves. So that that could be why some of the Section 126 relief from those caps may not be necessarily of immediate concern. But certainly, as as Joe and as Adam highlighted, to the extent anyone wants to share anything about partnerships that they have with non-IHS and tribal hospitals, any information along those lines, would be welcomed. But I certainly appreciate folks getting on the call today and hearing about the provision, given the comments that we got specific to IHS and tribal during the comment period. So I appreciate everyone coming in and listening, and certainly would welcome additional input in the future.
So Don, this is Dr. Carroll. I have one question that I was wondering if this section would be amenable to allowing tribal and IHS programs to, in essence, join together. For an example, say in the Navajo area where there are, 3 or 4 acute care hospitals, could they get together, develop a program, and then use this work to help fund the GME component?
So if they were starting a new program and they were, IHS or tribal hospitals, they would have an opportunity to establish a cap over a 5-year period. So this particular program, the 126 program, wouldn't really come into play because it's for hospitals that already have established a cap. And so, yes, those hospitals could definitely partner and start a program, and then that program would have a cap building period for 5 years. But this particular program, because it's designed for hospitals that are operating under a cap, that already have established a cap, it wouldn't necessarily come into play. But certainly there are opportunities even under our current regulations, putting aside the Section 126, for hospitals to begin programs and establish caps over a 5-year period. I think where this would probably, where 126 would come into play, would be more if a IHS or tribal hospital was partnering with a non-IHS and tribal hospital, and that non-IHS and tribal hospital had an established cap. That's where the Section 126 relief might come into play for that hospital.
So that would require tribal programs, IHS programs, to work with a larger medical school or residency system. An example might be the University of New Mexico would have a internal medicine residency program, and tribes could reach out to that program to work as a tribal facility that would be part of a 126 program.
Sure. In the New Mexico case, I think they're actually in their cap building period. So I think the 126 wouldn't come into play, but if there were a hospital that had an internal medicine residency program that was operating under a cap, then yes, the IHS or tribal facility, doesn't have to be a hospital, just anybody who wants to act as a training site for that program could reach out to that hospital, and the potential would be there for that hospital that's running that internal medicine residency program to get some cap relief from that. The only thing we just want to make sure folks are aware of is that when a resident does begin to train, if you are a hospital, IHS or tribal hospital, if a resident does sort of rotate there, that does trigger the beginning of a cap building program for you. You don't actually have to run the program yourself. Just by taking residents in, that would start a clock for your residency program. So just as I would advise sort of working closely with the hospital and with us or your regional office to sort of understand all the implications when you begin down the path of accepting residents. But yes, to answer your question, yes, that was a long-winded answer, but the short answer to your question is yes, IHS or tribal hospitals or even IHS or tribal facilities that are not affiliated with a hospital or owned by a hospital could certainly work with a non-IHS or tribal hospital to act as a training site for a residency program.
We do have a question, and for Jim Roberts, I think it's star 6 or star 1, Ashley. Which one is the one to unmute?
Yes, their line is now open.
Okay. Go ahead, Jim.
Dr. Carroll, can you hear me? Just a sound check.
Yes, go ahead.
Yeah, thank you. And I don't know if that was, I think was it Brooks that was discussing the issue, but just, in follow-up, my name is Jim Roberts. I work for the Alaska Native Tribal Health Consortium. We were one of the commenters along with the TTAG on this issue. And I think, our points were that, at least, I don't know that we necessarily meet all the eligible categories, but at least under the eligibility categories 1 and 4, as a rural hospital and Hipsa designation, tribal facilities probably are eligible for those various aspects. But I think you were hitting on the point that I wanted to mention on, which is kind of, I think the concern is, and the way we participate, the tribal system in this program is that you've got to be an accredited GME program, and I don't think there's one in a tribal facility that meets that requirement. There are a number of tribal facilities, as you were explaining, that have some type of affiliated arrangement. And the challenge is that the resources under those affiliated arrangements is that the resources likely go to the hospital that's participating in the GME program and may not necessarily trickle down to the tribal system that is providing the slots for residency in this type of arrangement. And how do we, the tribal system, become resourced to cover those costs in order so that we can participate? And I don't know if you all have any ideas about that. So I'd like to hear whether the proposed rule or the final rule now at this point would allow for that type of arrangement, and if there's confinements around that, how do we address those types of issues?
Sure. So the final rule is, as was the proposed rule, focused strictly on the implementation of Section 126 and how to go about handing out those slots to, as you mentioned, hospitals that have existing programs. In terms of starting up a program from scratch, separate from 126, that would be outside the scope of the 126 rulemaking, but perhaps I know HRSA has some programs that can help hospitals, rural hospitals set up programs. I don't know, perhaps that's a separate call or a separate line of inquiry for some of the resources that are available from HRSA. And I don't know, Dr. Carroll, I know you have some experience, some GME experience. If there's anything else you can think of, ways to help, or anything learned from the New Mexico experience about setting up these programs.
Now, I'm sorry, maybe I wasn't clear in the question. I do recognize that that's a separate process and outside the scope of the final rule. I guess my point is the tribal system meets at least two of the requirements of kind of the hospital types or locations of the hospitals. And there might be affiliate arrangements, which is the case in Alaska. There is one such arrangement there with the local hospital. However, the hospital will receive the resources while the tribal system provides the slots. And I guess the question is, how does this process allow for the inclusion of the tribal needs in that process, and also allow for the resources that might go to the local hospital to be passed on to the tribal system to cover their costs for these types of affiliate GME and IME arrangements?
So the tribal hospital could start its own, 126 is about cap relief. So it's about providing relief so that a hospital can take on more residents in its residency program. It's not like a check. It's not like a dollar check that gets cut to a hospital and say, go do something, go do something with your program. It's specifically to allow a hospital to expand an existing residency program that's operating under a cap, or establish a new program if the hospital's operating under a cap. That's how the law is sort of structured for Section 126. So there is no cap. So there's no cap for the tribal or IHS hospital. They could start their own program. There's no cap relief that's required. I thought you were asking, like, how would a hospital go out and starting a program? I'm not sure how to take the sort of 126 statute, which is designed to provide cap relief, and apply it to a facility that does not have a cap. It seems to be what you're asking, and I'm not sure. It's almost like the concept doesn't apply, which is why I was sort of heading down the path of how to have a hospital start a program, because that's how you would go about, establishing a cap over a 5-year period. But the statute is about cap relief, and the hospital that you're discussing, or the hypothetical hospital you're discussing, doesn't have a cap. Does that? I know it doesn't help, because what you're really asking is, can you get more resources for the hospital that has no cap? But the provision 126 doesn't. It provides cap relief, and if you have no cap, there is no relief that can be provided.
Yeah, but I don't think the slot that we have, and I don't know enough about the program, so I apologize for that, but I don't think the slots that we provide in this type of arrangement actually are our number inclusive of a cap. So I think they would be kind of measured in the participating hospital that's actually receiving GME funding in that process. So I guess the question is, how can the tribal system kind of impute its FTE needs into this process and not have it count against the hospital, the affiliate arrangement that we have in that process? And it sounds like that cap is already accommodated for in this process.
Correct. If the hospital that has the cap were to apply under the program.
Thank you.
We have a question from another participant, Douglas Nolan. Your line is now open.
Yes, this is Douglas Nolan. I'm with the Cherokee Nation. We have a family medicine residency program. Now, my question has more to do, the discussion you're having has more to do with the cap space and with CMS funding. It doesn't necessarily address funding, and I'm not sure that the way that the tribes are reimbursed through CMS, I'm not sure we would be eligible for any direct or indirect costs. Are you able to comment on that?
Well, certainly, if any IHS or tribal hospital wanted to start a GME program, then there's nothing that prevents that hospital from doing so and operating like any other IPPS hospital that starts a program. So the hospital could start a residency program, and then it would be eligible for Medicare to pay its share of both the direct costs of running the program, the stipends for the residents, and then the salaries of the teaching physicians and the overhead of the hospital, as well as indirect costs, which are sort of the additional costs that are associated with running a teaching hospital. We pay more per Medicare discharge. So certainly an IHS as with any IPPS hospital, an IHS or tribal hospital could start a program and be paid by Medicare, but there's no mechanism for, under the Medicare GME funding, there's no mechanism for funding to be provided to a hospital that's not a teaching hospital.
Okay, thank you.
Yeah.
There are no further questions. You may continue.
So, Donna, this is Dr. Carroll. I'd like to just circle back with you about the question regarding are there other opportunities for residents? And there are two programs I'm aware of in the country, one with Mass General Hospital and the other with the University of California, San Francisco. They have a HEAL program. The Mass General is a global health fellowship. So those are fellows that are part of the Mass General and UCSF systems that go out to tribal, Indian health and tribal sites for 1 to 2 years of global health type fellowship training. Are fellows equivalent to a resident, do you know? And those are the two that I'm aware of that have had great success with bringing two residency programs out to Indian country to work in. One is in Rosebud, I think Pine Ridge, and the other is in the Navajo area. So do fellows work as well as residents?
Sure, and it gets a bit into the cap and whether they're training over their cap. There's a whole bunch of nuanced rules that come into play. But generally speaking, there's nothing that we do pay for fellows, is the short answer to the question. But there's a lot of nuances in the answer that would be specific to the individual situation and the individual program.
Very good. So I guess part of my question is, or my comment is, so that if sites have interest, I could definitely help with connections to Mass General and UCSF to their programs, their global fellows, to potentially rotate through additional IHS and tribal sites. And then, Ashley, any other questions coming in?
Yes, we have a question from Melissa Gower. Your line is now open.
Good afternoon. This is Melissa Gower with the Chickasaw Nation. Can you hear me okay?
Yep.
Okay, so we at the Chickasaw Nation started our own tribal medical residency program a couple of years ago in affiliation with the Oklahoma State University School of Medicine. And we have been operating that program for a few years now. I know that this particular call is about Section 126 and the proposed rule, which I helped work on the TTAG letter for. But I really want to just give some thoughts and recommendations for CMS to consider that's outside of this proposed rule. When we very first started, we were looking for funding, much like what Jim was talking about, not being the accredited university that's doing the residency program, looking for funds for operational, startup, housing, all of those kinds of things that require funding by the tribe. And we had someone, our cost report people, to do us a feasibility study on accessing the GME Medicare slots program that you're talking about here on this call. And it really was not feasible for us to do that, and there were numerous reasons, and that's kind of what I want to talk about a little bit. One is that the program itself is very limiting on the items that it allows that are involved in the residency program, so it doesn't account for all of the expenses that we would have in operating a program. So that was one issue. The second was the actual cost reporting that has to be done for the GME CMS program. It's different than the cost reporting that IHS tribal hospitals are currently doing. And because of our special alternative payment methodology, it was an issue and just doesn't fit together. So that was another problem. And those things really go into the statement in the TTAG letter about it being too burdensome and not, really not enough, too many administrative requirements and not enough income to overcome that because of the cost that it would put up on the tribal hospital to have to do a different type of cost reporting and, the things that are not included in the reimbursement. So what I have been advocating for and asking for is for CMS to consider, and also we've been advocating in Congress for this, but was for CMS to consider actually setting up a tribal CMS GME program that's outside of this CMS GME program that really fits with the tribal IHS system to encourage and allow more tribes to develop residency programs. I know that we have one, and the Choctaw Nation in Oklahoma has one. Theirs is funded through a HRSA grant. We're using tribal funding to do ours at the moment. But I think in order for a lot of tribes to really set up some programs that's really going to have an impact on staffing shortages in Indian country, we're going to have to think about doing something that's a set aside just for the tribal hospitals under this program, or as a side-by-side program that fits us more appropriately to encourage them to do that. So I thank you for allowing me to make these comments. I appreciate it. Thanks.
Yeah, no, I appreciate the input. And yes, that's a little broader than the 126 proposed rule and final rule, as you mentioned. But as Joe, sort of mentioned at the beginning, generally speaking, on the Medicare GME side, there isn't a lot of flexibility. This Section 126 program is probably more flexibility than CMS has had in an extremely long time. With respect to the Medicare GME payments, the statute is very prescriptive in terms of, and even down to the actual formulas that are used in terms of how it's set up and how we pay it. Certainly, so I think you're right to be advocating on the Hill because within the context of the Medicare GME program, that would be beyond the statutory authority that we have under the Medicare GME statute. So I think that's probably if you did desire to have a separate IHS tribal GME program that would require a statutory change. But having said that, there are programs, and you mentioned the HRSA one, the support that HRSA was providing. There are other programs out there outside of the Medicare GME world. Granted, the lion's share of the funding for GME comes out of the Medicare GME program, but there are other sources of funds. And again, I'm not an expert on the HRSA GME world, but I do know they do have programs that perhaps might be of assistance. But unfortunately, within the Medicare GME statute, there's no authority for us to set up a separate IHS tribal GME program. Unfortunately.
We have a follow-up question from Jim Roberts. Your line is now open.
Yeah, thank you. I think my question was going to relate much to the same things that Melissa already brought up in the previous question asked by the gentleman that was on the phone right after I asked initially. But, it doesn't seem like 126 is going to have much direct benefit for the tribal system. I think there's some indirect benefits in that we may provide the slots for those institutions that might participate directly in the GME program. But my question, I guess, was going to be some of the things that Melissa brought up, but more so, now that she's brought those up, the question that the previous gentleman asked about funding is there anything that prohibits an institution that perhaps we provide slots for that might receive some of these resources from sharing those resources with the tribal system? So it wouldn't be the tribal system that's applying directly for the GME funds. That would come indirectly through their affiliate arrangements with the hospitals that they might have a partnership with.
So just maybe just get a few points of clarification or terminology down. So when you say provide slots, you mean provide training opportunities for residents in the program at the other hospital, just so we're on the same page. That when you say provide slots, that's what you mean by that. Okay. So, right. So if you're providing training opportunities for that hospital, then that hospital is only claiming the cost that they incur. So if they're continuing to pay the residents stipend, or if there's oversight by the hospital, by the teaching physician at the hospital, those are the type of costs that hospital's incurring that they're getting paid for. So it's not entirely clear, and this gets a bit into the weeds and nuances of how the Medicare GME program works. But when you say share resources, I'm not exactly clear what that means in this context.
Yeah, for
providing the hospital incurring costs.
You described, there's a cost associated with that perhaps from the tribal side, the tribal side isn't being compensated. So, this is certainly a very helpful conversation, and I'm learning about this process now because this whole program is relatively new to me. So I really appreciate you taking the time to explain some of my questions about this issue. But I guess, is there a way that the tribal system could provide its costs to those hospitals that are actually making the application for the resources to be included? So, I think where you were headed is that it doesn't make sense to perhaps pass through funding to those facilities that might be providing training opportunities because their costs may not be inherent in the actual entity that's submitting for the resources in the first place.
Right. So I think the way for the IHS or tribal hospital to be paid by the Medicare program anyway would be for them to start a program or become a teaching hospital, and then they would be able to claim the costs that they're incurring as part of the program, even if it was a program that they start with another hospital. They would be able to incur, their costs and their share of it, and then, they would be able to claim as any other hospital. It's not uncommon for more than one hospital to run a program, and each hospital reports its own costs associated with the time the residents are spending at that hospital. That's not unusual. So in this situation, from what you're saying, say an IHS or tribal hospital wanted to start a program with a non-IHS or tribal hospital, there's nothing that, as far as the Medicare programs, rules, and regulations in the statute, that looks the same as any two IPPS hospitals sort of joining forces. And yes, there's a process where each hospital gets paid by Medicare for the Medicare portion of its costs in running that program that they set up. So yeah, there's nothing that prevents an IHS or tribal hospital from doing that. But again, I think as one of the earlier callers had indicated, there are perhaps some cost reporting challenges that have maybe acted as a hindrance to IHS or tribal hospitals. But those are the same requirements for every hospital, and there's nothing, every hospital who's claiming Medicare GME costs is filling out the same forms the same way, and the definition of costs they're including is the same. But if a hospital is willing to do that, then sure. But again, if a hospital, if there needs to be some unique program set up for IHS and tribal hospitals, that's the sort of the route we were discussing earlier about the Hill. But to answer your question, no. I mean, the way the hospital would get paid for that is to become a teaching hospital.
Thank you.
Okay, there are no other questions. Speakers, you may continue.
Thanks, Ashley. This is Dr. Carroll. Don, any other closing comments for us today?
No, I appreciate folks. It's always good to have these discussions, and even if some of the context for the discussions, or even some of the scope of the discussions, sort of extends beyond necessarily what we're focused on immediately, which is the 126, Section 126 final rule. It's always helpful for us to get some insights into the broader context. So, appreciate all the callers who asked the questions and provided that input at the end, even if it wasn't directly related to 126. Again, that's always helpful for us in understanding some of the unique IHS and tribal needs, at least in this case with respect to GME. So appreciate it, but no, nothing else.
Okay, last chance. Ashley, any more questions coming in?
There are no questions at this time.
Okay. Well, I want to thank everyone for joining today's All Tribes call. It is in the CMS proposed rule for 2022. In the Save the Date notice is the link to the rule if you're so stimulated to go read the rule. And if you do have any comments or additional questions, please do send us an email at tribalaffairs@cms.hhs.gov, and we will get those out to Mr. Thompson and his team. Otherwise, thank you again for joining us today, and this will end the call. Everybody have a great afternoon. Thanks again.
This concludes today's conference call. You may now disconnect. Call, 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 you may now disconnect.